It also was designed several years ago, and at the time when next generation sequencing was becoming very, was novel, was new in the tissue, let alone in the blood, and doing panel testing and such, and also targeted therapies for small populations of patients within each group of diseases. So the challenge there that we could foresee was that it would be hard to prove the benefit of a given targeted therapy for a very small subgroup of the patient population, because it would be difficult to accrue to such a study. For example, of which there are many, but an example is, say, MET amplification. MET gene amplification occurs in about 5% of gastroesophageal cancer. And therefore, to do a prospective randomized phase 3 study, you would have to screen, 20 to 1 just to find that many patients. And it's hard enough to do, a normal phase 3 study for all patients without selection. So this becomes very prohibitive and was very challenging. Even at the time, you could foresee that that would be an issue. And in addition to that, there was evidence that even within a patient, so not only interpatient heterogeneity of all the different genetic events of which slices the pie into multiple different subgroups, but even within a patient, there was evidence that we had shown and others had shown that you could have different molecular profiles within the same tumor bed in the primary tumor, and also from primary tumor to metastatic site. And so this intrapatient heterogeneity also added another layer of complexity to be able to bring our therapies forward and to fruition so that patients can actually benefit from them. So for this reason, we designed a study that would biopsy both the primary tumor and the metastatic site, and be able to sort of evaluate and really chronicle what is the difference between them and what's the incidence for various biomarkers, and does it make a difference? Would it change their therapy if you assessed by the metastatic disease, which ultimately is what causes most symptoms and also causes the patient's death eventually? Maybe if we target that, we could have more benefit. And then in addition to that, we recognize intrapatient heterogeneity over time. So not only at baseline spatially, but also over time, as you did target a certain therapy towards a certain genetic event, that inevitably you would get resistance, and those resistant clones, we wanted to sample, reprofile, and then retarget our therapies towards them. So going along all of these interpatient, intrapatient molecular heterogeneity problems, we designed this study to sort of try and tackle each of those all simultaneously, which we felt would be sort of an ideal way to get at the root of the problem. And the study, therefore, had what we called a biomarker assignment and treatment algorithm, which would perform molecular testing, of which included next generation sequencing and also some protein analyses, and then prioritized various subgroups within the disease that we thought would be the highest likelihood of benefit, and then towards the bottom, and ultimately all negative for every other molecular biomarker group. Those patients would be called a sort of an all negative group. And each one of those groups, of which there were 8, would get an assigned therapy for them, a specific monoclonal antibody that would be added to standard of care chemotherapy in the first line setting. And then this would be done again in the second line setting and again in the third line setting, trying to keep up with the tumor, so to speak. And ultimately, the primary endpoint was overall survival, median overall survival. And the primary endpoint in a single arm study, the hazard ratio target was a 0.67, and that translated into a 1-year overall survival rate of 63%. And we reported the first report of that at GI ASCO this year, 2020, which it did meet its endpoint, primary endpoint, 1-year overall survival was 66%. And we provided some updated analyses at ASCO 2020 this year, and the manuscript is in publication now. So some secondary endpoints of interest was that the primary, the response rate was 74% in all comers. And the patients that were at the higher end of the algorithm did better than those that were at the lower end of the algorithm, which was expected and anticipated. That's why they're prioritizing the algorithm as they are. Yet the patients at the lower end of the algorithm, which were still getting targeted therapies along the way, did better than historical controls. So overall, as a phase 2 pilot feasibility study that met its primary endpoints, it's promising, and it warrants further prospective analyses, preferably randomized, so that we can move this sort of a personalized treatment strategy towards an accepted standard of care.